Hello, this is Ferris Taylor with the Healthcare Executive Group. We'll be starting the webinar in just a minute. Thank you for waiting. Thank you for waiting. We will start in just a minute. Good afternoon or good morning if you're on the Pacific time. Thank you for joining today's webinar. I'm Ferris Taylor, the Executive Director of the Healthcare Executive Group, and today's presentation will be led by our new gold sponsor, EQ Health Solutions, and is entitled Solving the Rubik's Cube of Payer Data. Welcome. As a few housekeeping items, all participants will be on mute. We should have time at the end of the webinar for questions, so type any questions that come to mind during the presentation into the question box in the lower right-hand corner of your screen. And of course, you can visit eqhs.org for more information on today's webinar and other important healthcare topics. As quick background, the Healthcare Executive Group is a national network of healthcare executives and thought leaders working to make positive changes to the healthcare industry. By facilitating knowledge sharing events like the webinar today, blogs and white papers, we help advance and shape industry-leading discussions. You can learn more about our thought leadership and our networking opportunities at our website, which is hceg.org. And we'll be sharing that later in the presentation as well. Next slide. Throughout the years, our members discuss and deliberate technology and innovation opportunities, issues, and challenges in healthcare. During our annual forum at the end of the year, we formally vote on an HCEG Top 10 list for the next year. Today's webinar series event will focus on our 2019 #1 Top 10 issue, which is data and analytics. It was also the #1 issue in our 2018 Top 10 list, primarily because of both clinical and social demographic data that is becoming much more available and, of course, much more critical to innovations and advancements in healthcare. Our webinar today will be led by Mayur Yermaneni, Mayur, Chief Strategy and Growth Officer at EQ Health Solutions, alongside Marina Brown, EQ Health's Vice President of Clinical Programs. I'll let each of them introduce themselves and kick off the presentation. Mayur, I think you were going to kick us off.
Thank you, Ferris. Thank you for that introduction. And like Ferris said, my name is Mayur Yermaneni. I'm the Chief Strategy and Growth Officer for EQ Health Solutions. I've spent all my career in healthcare space, all the way from medical devices to pharma to pharmacy and hospital industry, and actually helping insurance payers and actually helping develop their strategies and product portfolios. For the last 10 years, I've been with EQ Health, where my role is basically to understand and anticipate the industry and market evolution, and based on that, develop the products and services to help grow the company. And a key aspect of that one is see how things have been in the past, and then see how things are headed. And that could be because of a regulation that's coming out, or because of the new technologies that are coming out in the market space, and see how the industry itself can evolve based on those dynamics in all aspects, and see how we can actually leverage that and actually benefit the overall industry as well. That I'll let Marina introduce herself.
Thanks, Mayur. Hi, I'm Marina Brown. I am the Vice President of Clinical Programs for EQ Health Solutions. I am a registered nurse and certified case manager. I've been a nurse for 20 plus years, spent a lot of clinical practice in the hospital and also doing hospice care. For the last 15 or so years, I've been working in case management, both on the payer side, and then 10 years ago came to EQ Health Solutions, working with commercial and government Medicare, Medicaid recipients. My role with EQ Health is to help us develop a care coordination service model that touches and is effective in managing diverse populations, as well as being the clinical consultant for our software solution. The goal of my role is to ensure that our service model and our software continues to evolve and innovate with the healthcare community, and striving to really introduce those best practices into the way we manage patient populations. Mayur?
Thank you, Marina. So at a high level, today's agenda is we're going to talk briefly about the current state of the payer market and the future considerations, and this Rubik's Cube of payer data and what the current scenario is. We're going to also talk about what tools and technologies will lead to the continued payer success, and what are the top 6 things to consider when evaluating a healthcare analytics vendor. So getting started with the current state of payer market and future consideration, I'm going to generalize some of these themes, but across the board, I'm sure some payers are at a above average spectrum of where they're seeing these trends, and some payers are still in the infancy stages to actually see the impact of these trends. But so this will be all over this. So I'm trying to generalize some of these themes so that everybody can actually benefit from it. So across the board, one of the key things, and I guess this is not unique to the payer market itself, margins are decreasing. With every regulations coming on board, there are more and more cost burden associated with the payer market. And that you actually have to come down to almost correlating that to is, well, are payers becoming a financial institution? From that standpoint, now we are actually paying in the margin space. But because of that, one of the other things that's happening is mega mergers. And you see this a lot more in the bigger payers like Aetna's acquisitions, United's acquisitions, WellCare, and all of these acquisitions that are happening is to counter their decrease in margins by creating economies of scale that they could benefit by actually saying, okay, if I can actually acquire another of these entities, I can create a cross burden rate across the common units and hopefully benefit from the margins play game. Data security. Nobody wants to show up in tomorrow's Wall Street Journal. In the current day and age, there's an entire team dedicated just so that payer's name doesn't show up on tomorrow's newspaper, primarily because with the PHI information, the abundance of PHI information from all different sources, it's extremely important to say, well, how do we protect our data? The data that, especially the payers, have a lot more data than anybody else outside of providers, and there are 2 different spectrums of the data set. So, and they both are equally critical from the standpoint of ensuring that data security is a key aspect in your space, because today's 100 records or 500 records, anything above that threshold, you're going to have to report it. So data security becomes actual strategy nowadays. Is how do you make sure that your data security is actually playing to your advantage, and your customers have to be able to trust that. And that trust is what's going to actually give you, even though that has nothing to do with the actual plan itself or the benefits that they're receiving or the care that they're receiving, but they still have to be able to trust that their data is secure. And finally, when it comes to the actual providing the value of it, this is the data set the payers are actually having to wrestle with is how are we showing the value that we are providing to the hospital segment, the provider segment, and the member segments. So that's another key aspect of it. But if you look at it, that actually is one of, before you even get to that value component, you still have to deal with all the other aspects of administrative side of data security, operations margins, and everything. Well, how is that actually happening? Big data. Well, I'm not going to bore everybody with the data, what the definition of big data is, but in a nutshell, in today's world of Instagram and Facebook, Snapchat, it's all about the volume and speed and the frequency of the data that you're receiving. And in the payer market, it's a lot. I mean, you're pretty much today, where it used to be a monthly fee, now it's an API call or HL7 message, which is instantaneous. And the amount of frequency that you're having to deal with is a lot more than what you had before. And the amount of types of data that the payer market is actually having to deal with is a lot more. And even in there, the data can be segregated into a couple of different ways. The data that is the primary data sources and the derived data sources that you're generating as a result of your operation, or as a result of some of the analysis that you're doing on top of it. So that's another big trend that the payer market is having to actually wrestle with. Ferris indicated that this was one of the top topics actually even last year as well, and social determinants of health was one of the key aspects to it. And that hasn't changed. What has changed is how that's being viewed, instead of as being a peripheral data source to actually making that being a central component to how your operations need to be done from a social determinants of health standpoint.
And Mayur,
Marina,
if you don't mind.
Go ahead.
I was just going to say that I do think that this is really a big one for the industry. Social determinants of health are definitely going to help change the way that we deliver healthcare, and that's a very important distinguishment. It's not going to change the way that we do healthcare because we treat a diabetic the same, but it will change the way that we deliver care simply by helping to better guide the interventions that we're utilizing to create more meaningful behavior change over time. So back to you, Mayur. Thank you.
Thank you, Marina. Another key aspect is artificial intelligence. Now, again, I don't want to get into the definitions of artificial intelligence, but the key aspect of is with the advent of big data, with the advent of amount of data you're having to deal with, well, it's not humanly possible for a supervisor or a manager or a management team to be able to assimilate all that data and actually say, what am I making use of this data, and how am I going to make use of this data, and what decisions am I making? So artificial intelligence or machine learning, they're not necessarily synonymous, but in some aspects they're synonymous from combining the wealth of data that you're getting and actually saying, what insights can I derive based on all those data sets at a much more faster pace and a timely manner compared to what we would have had to do if we were doing it manually. And there is an element of how do we use the machine learning algorithms or artificial intelligence approaches to say, can I do a better prognosis? Everybody's aware of the Watson's cancer cure approaches to it, and Watson has evolved into a lot of other stuff. But predominantly in the mainstream, the payer market, this hasn't yet taken into a full-fledged prevalence because we're dealing with not necessarily a literature research, but more in the realm of operational research, operational analytics. How can we employ artificial intelligence or machine learning concepts into the operational realm of the payer operation? There are some positive trends. What we're seeing is that there's a huge growth of MA plans. Their margins continue to increase because it's a catch-22 situation for MA plans, because the risks now MA plans are able to accurately actually reflect their risk scores, and as a result, their premiums are being reflected the right way, which actually helped them from their margin standpoint, because their operations were still on the same aspects of it, because in the previous era, they were not reporting the risk the right way because they didn't have all the data gathering opportunities. But now that they're able to gather their opportunities and you're able to predict the risk a lot more accurately, their premiums are going up. As a result, the margins are getting better, and also the operations have stayed the same. And in the Medicaid managed care space, what you're seeing is a lot more growth in that opportunity space for predominantly, we could say it's one single reason. Most of the state administrative entities are actually trying to offload the burden onto the plans so that the risk is being passed on to the managed care plans, and the state entities are become the administrative agencies. Of course, with that, they are also holding performance measures as an accountability, which is not just about the financial side of it, but also the quality side of it, because they don't want to sacrifice the quality of care being rendered to their beneficiaries. But as a result, you're seeing a lot of growth in the managed care space, Medicaid managed care space. Well, what does this mean to me or my organization as a payer? If I actually eliminate all the big terms, fundamentally there are two simple concepts. Is our plan performing better than what it was before from a cost standpoint? And with the qualifier being added saying, is the plan performing to a level which the plan can afford to? Because what you're collecting, to your risk, to what you're paying out. That's one of the key foundations. That's a simple question that you're going to answer. And the second aspect of it is, are we improving the quality of our plan? And the quality can be defined in multiple ways. I think, the star rating, the HEDIS measures, and all that stuff. But at the end of the day, it's really, are you improving quality in terms of outcomes for the members? And the second point is actually impacting the first point from a long-term standpoint. So if you're impacting the quality aspects of it, then you're able to impact the cost aspect of it as well. But it doesn't happen every year. It happens as a strategic view of, you have to put that as a strategic view, long-term view, so that on a short run, your cost structure might have variances, but over a long run, you're actually improving the trends of that one. So, but what does that mean in terms of a payer when you think about how you have to think about it? It comes down to two things: operational efficiency and health of your health plan. How do we make a difference in looking at all the data that we have and actually answer these two business questions, and then tie them back to the simple questions of, am I performing better in terms of cost? Am I improving the cost? Marina? You want to
Thanks,
talk about this?
I'm sorry, I cut you off by accident. Just kind of talking a little bit about operational efficiencies. I think as operationally, looking at the data is really going to, as a program administrator, it's really going to give me insight into things like what care management programs or medical management programs are most needed for my population. What programs that I'm currently utilizing are really the most effective ones. Taking that a step farther, as you look into those specific programs that are most effective, you'll also then be able to look at things like, what are the interventions that are most effective in this population? From a utilization review perspective, is my UR working only as a gatekeeper for my health plan, or are we actually effectively managing acute episodes and beyond that acute episodes? And then really helping us determine all of this ultimately helps us determine what care intervention strategies do we need to tweak, which ones do we need to add to our programs to create that meaningful behavior change that increases the health of our membership, increases the quality of the care that's being provided to that membership, and ultimately reduces the cost. Mayor?
Thank you, Marina. So how do you view this from a current situation in your operations? Payers are sitting on a lot of data, from your eligibility data to your claims data to your analysis data, UR data, care management data, and a lot of that data set is actually adding up to the big data concepts. There's a statistic out there which actually, according to the AHIP, you have regional payers are spending approximately $8 billion in claims each year. Now, we can argue that number being up or down, but at the end of the day, that still is a lot of data set. And that's just a cost figure, but that doesn't even reflect the operational data set that you're actually having to deal with. So from So in addition to trying to find the best way to maintain the data, many payers are having to address the problem of operational reporting standpoint. In a lot of ways, payers are struggling between, am I doing reporting or am I doing analysis? And how am I looking at it? Am I doing the analysis for the sake of reporting, or am I doing analysis for the sake of improving or answering the two questions that we started out with? And those could be the patient member outcomes, quality standards, star ratings, keeping benefits costs down, maintaining their profit margins, improving efficiencies. All are these questions that every payer is asking. What am I not tapping into that I should be? Or can I predict the trends? How can I harness the data to identify opportunities for improvement for my members and patients? How can I use the data to help lower costs? How can I improve the patient care? How can my data help me improve my quality measures? What is the latest and greatest technology out there to create efficiencies for the overwhelming amounts of data at our hands? And the list goes on, and you guys are actually dealing with it a lot more in today's world. I'm sure every organization has a ton more questions to add to it. But fundamentally, why and how to do it is where the biggest question comes into play, because often everybody goes down the path of, okay, I need to solve this reporting problem, so I need to have this kind of technology in place. I need to solve my data analysis problem from a predictive modeling standpoint, so I need to have this technology in place. And as a result, you're creating more and more silos within the analytics space. And not necessarily taking advantage of the full spectrum of the data that you have or creating in its entirety, in a holistic view. Because at the end of the day, if the analytics is being used just for the reporting purposes, then you've only solved 30% of your problems, because majority of your problems are still deriving insights from your data and actually saying, how can we make a difference in our operations? How can we make a difference in our outcomes? I hope this kind of gives you a good, pictorial view of what's happening. You can see this truly is, you have multiple data sources and everything is being viewed as a silo. And if you look at it, the way it's organized, not necessarily every one of them is talking to each other, because they're all trying to solve a problem for the operation that they were designed for. But holistically, at the entity level, have we designed the data problem in a way where it's actually driving down the holistic view of it? In our view, what we have seen across the industry, in the payer market, it's not happening. And there are organizations who are much more mature than the other, but fundamentally, they're still struggling with the aspects of, am I doing quality analysis? Am I doing financial analysis? Am I doing operational analysis? Or am I doing just reporting for the regulatory agencies? And they're all solving those problems, but they're not maximizing the benefits you could derive by actually putting them and actually saying, how can I turn that whole view into a key aspects of designing your operational strategy in such a way that you're taking advantage of all quadrant of dimensions: quality, financials, operations, and predictive. So how do we go about it? what are the tools and technology? Before we get to the tools and technology side, I want to talk briefly about what are the key components that are going to make a difference. Earlier, in the previous slide, you saw the Rubik's Cube. Each role was actually solving the problem. They were addressing the need that they were asked to do, but they were not paired with the two components. Often what happens is an analyst is being asked a question, and they actually come back, and that data set is then presented to a clinical leadership, and actually clinical leadership are then asking a follow-up question and then making some decisions on top of it. But in reality, what if you actually change that and actually bring that clinicians up front during the analysis itself along with the data scientist? So what we view in the industry is we think there's a lot more benefit if you actually pair the clinicians and the data scientists together up front in the design and analysis phase, so that you're not having to, one, you can cut down your cycle time, and two, you're asking the questions up front and how to think about your operations. And that's going to actually design your reporting and analytics problems in a way where you're actually getting to that in a much more faster approaches to it. That's
Mayur, I think that's,
yeah, go ahead.
Yeah, I think that's a really important point that you're making. I think bringing these two teams of people together really, as you said, it really helps to bring about that important balance and maximize your outputs, because your data scientists are experts at identifying the trends in the data. And when that information is presented to the clinicians, they can then help interpret those trends. That's going to ultimately formulate your adjustments to your operations, your program design, etc. So I think that's a great point.
And another aspect to it is, when you're thinking of a clinicians, you're actually taking away their valuable time in actually working with the member if you're actually asking them to do the understand what's happening with the data and actually going through the exercise and then making the decision to it. But if you pair them up front, you've actually solved the problem, and then you're giving them time to actually have their teams focus more on the members than they are focusing on the data itself.
Right.
Well, that's
again, I think, yeah, those care teams, they're so busy trying to make that outreach to the members that definitely having that technology available to them to be able to guide them to the identified trends or issues with that particular member is going to save time, and it ensures too that that all of the important or pertinent trends for that particular member or that particular population are being identified. Because at the end of the day, clinicians are just that, clinicians. They're not data analysts. So again, thank you for sharing that.
So you've solved the design problem. You have how the teaming needs to happen. But then now you need to think about, how is the platform designed? Is the platform, is it intuitive? Is it easy to use? Is it giving the full picture of the data set? And that's where your business intelligence platform comes into play. Because, and with the platform, you can have the best platform in the world, but if you don't have the right people actually thinking through the data set, you've invested in a heavy piece of electronic paperweight. And that's the key to understanding that you have to have both. The platform that actually going to give you a 360-degree view of it. And I spoke earlier, you have the quality data set, your chief medical officer actually looking at all the quality side of it, your CNO is looking at the quality side of it, but then you have a COO who's also looking at the operational side of it. You have your financial side looking at, how's my cost spend, PM spend, PPM spend. Are they all not correlated to each other? Can we not take advantage of those things together? That's what it's going to come down to, is how do you optimize in a multidimensional view to actually make the right decision? Because if you were to make a decision just on a quality analysis standpoint, your operations team might, let's say, identify subset A as a population that you're working with. Now, if you, in an independent silo, you go to a financial team and actually say, well, where's my PMPM spend? And give me a subset of population whom I need to focus on. That might be a subset B. And then you go to your predictive modeling team and actually say, well, how is the data coming together? Who's going to cost more in the next year? Well, that's my subset C. Well, reality is there is an overlap in all of those subsets, and there is an overlap. There is a not mutually exclusive groups too. But how do you create a decision-making framework where you're taking all those multidimensional view and actually creating a 360-degree view? Because by the time you give the subsets to your operations team, in this case, a nurse to actually work with, even the nurse at a member level is still doing the same exercise. They're looking at their quality aspect, they're looking at their cost aspect, they're looking at their financial aspect, and saying, okay, where do I focus on? And you have to have all that 360-degree view of the member to actually make a decision. And all this just with the data sets that you do have. And now imagine if you actually now starting to integrate, and some organizations are already doing this, is I want to integrate the provider data set, which is their EHR data, qualitative data, the session notes or the plan of care that you're generating. There's a corollary to that in the EHR space. Well, I want to integrate that data set because the care manager is wanting to have all that information to make the right decision. That gives you the full spectrum. To do that, you have to have a platform which allows you to, one, draw an analysis and then present that 360-degree view, which is in a consumable way they can make a decision. And I touched on this a little bit, where at the end of the day, it's really identification of high risk and high cost patients. But how you get to that patient subset is going to be critical, because to my earlier example, if you get to that subset through a quality dimension, you will come to this one subset. If you come to that same subset through a financial, you'll get to another subset. It's really making sure that you're taking all dimensions into consideration to get to that subset. And of course, the predictive trends. Today, for the most part, high risk and high cost patients are, in a lot of ways, are retrospective analysis. And today that happens, the trigger points might happen through an ADT feed or a census data, or somebody got a prior authorization request. And so if you look at it, it's already after the fact. But what if you could schedule somebody to actually come to your clinic, or you want that member to have a visit to a PCP based on what you have done? That would be shifting the paradigm. Because at the end of the day, if you're not able to shift the paradigm to schedule proactively who should be at the hospital, at the PCP site or a hospital, then who is, then we'll be having the same debate again in another year. In 2020 as well, we're going to be having the same top 10, analytics is going to be top 10, because we still haven't focused fundamentally changing on the paradigm of who is going to or who should go to. And finally, nurses are superhumans, but they only have so much limited time to engage that member. So in order for them to maximize that time, they need to have actionable insights that they can actually work on. And that's another aspect of a 360-degree view I was talking about earlier, where you look at multidimensional view and actually say, what are my actionable insights? Taking into account all those dimensions, which one should take a priority, which one can actually have a long-term view, which one should be an immediate view that you have to act on. And finally, it goes back to the real-time aspect of it at the right time. Do I want to act this when somebody showed up at the hospital, or do I want to act it in a way where we're asking them to show up at a visit because of what we have actually drawn from the insight standpoint? And that's the situational awareness. And you're changing that situational awareness to what it was to where it should be. And now what if we actually change that same Rubik's Cube to a paired approach and actually look at the Rubik's Cube as you have now created a pattern in all aspects of it, and they're all working together. You cannot solve the Rubik's Cube if you don't get all the colors together in all aspects of it. You can't just say, I have one face all completely solved and the others are not relevant. You have to have all those aspects of it. Now, you might question to say, well, am I not increasing the overhead by actually creating so many paired aspects to it, increasing the paired concept of data scientist and a clinician. In reality, is you're really not, because you're today doing it. Today you're doing it in a sequential way where the data scientist is actually doing the exercise, then passing it on to the clinician, and clinician is making the analysis, driving their own conclusions, and then going back to the data scientist. What we're saying is that same design concept, if you tweak the design itself to do it in a paired approach, you might be answering the questions that you should have been answering right from day one, as opposed to day 10 today. And how you get to that, you might be seeing a lot more different patterns. You might be seeing a lot more different questions that you could be answering, or the questions that you might not even have asked, even when your design is happening. Because by the time the design is done, you've already narrowed down the questions that you will be answering. But if you brought up the clinicians up front with the open-ended view, the possibilities opens up of what kind of questions you could be answering. How do we get there? And these are in our view top 6 things that you should consider when you think about analytics, or in the maturity of where your organization is and how you want to get there. Data security, and I cannot say enough about data security, because it's not just about reporting or not showing up on the paper. It's also about the trust that the members or the organizations want to have to say, well, can I trust this entity based on the data that I'm actually sharing about my data to them? In-house experts, the data scientists, the clinicians, because the clinicians know the nuts and bolts of the operational view, and they're able to actually communicate how does it work from an operational viewpoint. And the data scientists can actually help them based on how they're trying to think through the operations. What questions are they able to answer? Or should they be asking a different set of questions based on what they're seeing in the data set? And it's pairing those data in-house experts, because if you create a siloed approach, then you'll still be wasting your resources in a way where they're siloed, and you're going to perpetuate the inertia that the industry has been suffering with, the siloed mindset, siloed mentality of, well, I'm going to share the data when I'm asked to. Well, that's not going to help you solve the 2 basic questions that you're trying to answer. Intuitive, easy to use platform, because it's a lot of data, and the frequency of that data is huge. So how do you create a platform where it still is consumable based on all that data sets? Actionable real-time data visualization, data accuracy. Well, I can have, again, a great technology platform, but if I don't trust the data coming out of it, or accuracy of the data that's coming out of it, adoption rate of that platform is going to be very low. Because if the data itself, if let's say you're not able to answer one of those questions accurately, well, that leads into the doubt of, well, is anything coming out of that system accurate? Can I actually rely on the data to make my decision? So it's a key. So in a lot of ways, the data accuracy should be upfront in your design itself. So, but then also you can't improve the accuracy unless you also start understanding what the operational framework is. And finally, one of the biggest barriers that we've seen in the industry is the data formats. Whenever you create a barrier for an entity to share the data by saying, well, we want this data in this particular format, you've just created a barrier for them to actually share the data with you. So as a pair organization, if you're able to create the bandwidth in your organization to say, we'll accept any data format that you may have, as long as it has the minimum data set, we'll take on the burden. It's not just you're able to creating the bandwidth, but it's also vice versa too. When somebody else is asking the data from payer organizations to say, are you able to support it as well? Can you give them the data in any format, and not just say, this is the only format, we're not going to change it, and it doesn't have the minimum data set? Then you're defeating the purpose of how you can actually make the information more usable from that entity standpoint. And it goes both ways, both the providers and the payer side of it. So that was basically the concept of what we're seeing in the major trend standpoint. I wanted to briefly talk about who we are. EQ Health, we've been a clinical organization, clinical services company since 1986. We serve members in 50 states, and you can see all the office locations that we have. We are URAC accredited in both health utilization management and disease management. Across the board, we manage, whether it's in our services side or whether in the technology side, at least 10 million lives. We're a 400 employee company serving 50 states. We've been in existence since 1986. Organizationally, everything that we do is driven by clinical teams, clinical leaders. Marina is one of our clinical leaders who actually helps design some of these systems. Half of our board is medical directors, physicians, and we have a medical director forum. We have full-time medical directors in-house, 190 plus nursing staff, and a physician panel that we can access. These are physician panels that we don't rent from somebody. We actually built our own physician panels. And then we have PhD and master level statisticians. And then we have IT team. At the end of the day, we have to have a very good data science group and the IT group, because you have to have the infrastructure in place to actually help solve some of these problems as well. And then finally, we also have operational, multi-state operational capability, bringing up an entire statewide organizations to a small scale ACO or a regional payer or any of that. From our solution standpoint, we have our technology platform can be broken out into 3 different modules. The clinical integration framework, which is our data aggregation suite, where we're agnostic to what EHR you may have or what kind of payer system that you have. We can actually aggregate all the data sets. And then our business intelligence and analytics platform is our analysis module, where after the aggregation layer, the analysis framework actually allows us to say, well, what insights can we draw based on that one? And that takes into account not just the primary data source analysis, but we integrate the predictive modeling, the quality analysis, gaps in care analysis, and we also integrate the machine learning and artificial intelligence concepts into our system. And finally, after all that stuff, you still have to have a platform where the nurses have to actually work with the actual members. That's on our technology platform. And on our services side, it's our population health. We provide population health services where if a payer organization wanting to, from a scale standpoint, expand their services, but they don't want to expand their current operational standpoint, we can actually become the services arm. Because that's how we grew up. We started out as a services organization, and to do that effectively, we built the technologies in place to do that. Medical management. So if somebody wants to actually do both the prior authorization and the care management, case management, disease management as a package scalability solution standpoint, we actually do that for self-insured plans, regional plans, Medicaid agencies, state entities that we do the prior authorization as well. And then we also provide the Medicare chronic care management services. We've had recent awards. For one of our recent awards was in CMS awarded us for the amount of lives we saved and the cost savings, 19.8 billion cost savings. We were also recognized as the top 20 leading IT solutions provider. So we're both in the services space and in the technology space. At this point, we wrap up the presentation and want to open up for questions.
Mayor and Marina, we've had a few questions come through, and I will go through those. The first question is, our organization currently executes minimal analytical formalities, processes, etc., and we are at such a mature state, analytical state. Would investing and working with an analytics vendor be futile at this stage in our organization?
No. So you can view it from the standpoint of if you're in the early stages of maturity, then that would be the perfect time to actually say, how do you want to design your systems? How do you want to have, what kind of systems do you want to have in place? And you may not have to go to the same evolution steps that the entities who have started out early on. You may actually leapfrog by actually taking into all that stuff upfront itself. So absolutely. Even if you don't have all the data organized in a unified view, that's fine too, because you do have data sets. The first steps very well could be, how do you get them into the unified view? So I wouldn't hesitate of actually working with investing in analytics if you're in early stages of maturity, because this very well could be an opportunity where you don't have to redo some of the things that you might have done if you're already in the further stages of it.
Okay. Next question. Our organization prides itself on taking the best care of our patients. With that said, can you give us examples of how using an analytics vendor can improve our patient outcomes versus just us monitoring it internally?
Mayur, would you mind if I gave a quick example on this, and then if you have other insights?
Go for it.
Okay. EQ Health, as we mentioned a little while ago, we also provide services, and we have provided services in the Mississippi Delta. And part of that time period that we've been providing services, as you start looking at data, we noticed things like there was very high utilizations of the emergency room and inpatient admissions for diabetic members in that particular area. Now, the first thing that most care coordination, care management programs think of is we need to educate our members on they need to stop using the emergency room for a primary care physician's office. If we get them into the office better, then they won't be going to the hospital in the emergency room for elevated blood sugars. And so our care team initially started out with that kind of concept and frame of mind in place, actually going out and we identified those members who were the highest utilizers. And when I say high utilizers, I mean 12 or more inpatient and ED visits strictly for elevated blood sugars. We identified those members, we reach out to those members, and we start educating them on what's appropriate to go to the emergency room versus what's appropriate to go to a primary care physician for. Then as you start talking to this membership, you start to identify other things. And as you start talking to your analytics team, they can start to bring in other pieces of the puzzle for you. So as you start looking at the data, we started noticing, is there an access issue? Because if everybody's educated and they know they shouldn't be going to the emergency room for blood sugar, they should be going to their physician, then maybe it's an access issue. When you start examining the provider network, you see, no, it's not really an access issue because there are physicians in the area that are able to treat these type of things. As our analytics team starts to bring in things like social determinant of health data, we start to see that this is a very low literacy area. This is a very poor area. Unemployment rate is over 60% in this particular area. So there are some social determinants that could possibly be contributing to this. And then the final piece that we took in was actually looking at the information that our care coordinators and our care managers were gathering and talking to these members. And our analytics team, working with the clinicians, started to notice the pattern. The problem wasn't education. The problem wasn't access. The problem was that this is a poor community. It's over 60% unemployed. And as nurses were finding out, those unemployed members felt like they had to make a choice between providing rent and a roof for their family and their children versus getting their medicine. And the only way that they knew to get their medicine was to run out, let their blood sugars get really high, and then go to the emergency room. So that they could get their prescriptions for free and they would have enough medicine to carry them on to the next month. Once this pattern was identified, it helped our team to be able to re-engineer our program and our interventions to say, guess what, members? Did you know that there is a community pharmacy program available to you in your community, and it is able to provide you your insulin for a $2 fee? So once the data and the analytic tool was able to actually help us identify those trends and that root cause, we were able to tweak our program and actually provide the right interventions to that population. And then we started to see those ED visits and those inpatient stay actually reduce over time.
Thank you, Marina.
Thank you, Marina.
Another question that has come through is, my team is discussing the decision to build an analytics platform internally, or do we buy and outsource it with a vendor? Do you have any insight to what is shown to be more successful, any pros and cons?
Yeah, I don't think there's a right answer, right or wrong answer to it. It really comes down to from a strategy of, are you trying to make that as your core competency, or are you wanting to retain your core competence to actually managing the plan operations, but want to have the benefit of the analytics and the analytics platform? Then at that point you should outsource it. But if you're wanting to make that as a core competency, then you need to have that in-house. But when you do decide to make it in-house, you still need to rely, well, what does that mean to being in-house? Is it, I want to have subject matter experts in-house who actually can answer those questions? Or do I want to have subject matter expert who actually can design those systems in place? Fact is, as payers, you're not in the business of, in the software business. You're in the business of actually plan operations. Well, in that case, you really have to decide, how do you want to weigh that operation from your strategic standpoint? Do you want to make that as a core competency to build a team in-house but have a system being outsourced? Or do you want to outsource everything and then take advantage of that integration within your systems to perform the care management operations? So it really comes down to how you want to view that as a core competency.
Thank you, Mayor. Another question that has come through is, what is EQ Health ramp-up time for their analytics offering?
So if we were to take in all your data set, the claims data, eligibility, operations data, and prior auth and everything, we can ramp up from the day we sign the contract to actually system being used is anywhere from 90 to 120 days. And that's a full breadth of implementation, meaning from data integrations to testing to designing the views, the dashboards and everything to your needs, to actually being the nurses actually starting to use it. And then because we have our platform actually allows you to actually even perform the care management operations, if you want that as well, we can do all of that also within the same time frame. So we implement that as a parallel work stream.
Thank you, Mayor. Looks like we have time for one more question. My organization already has a sophisticated internal analytics department. Will working with analytics vendor be any additional benefits? If so, what?
So again, I think this goes back to my earlier comment of how do you want to view that as a core competency. If you already have an analytics department in-house, then you've already made the decision to make that as a core competency for your entities to say that you want to have that in-house. But at that point, do you have the systems that your analytics teams need to help your organization? At that point, you may want to choose to excise the value of, well, what systems, what tools am I giving my team to answer my questions? At that point, you may want to work with the analytics vendor. And that analytics vendor will have to work with your analytics team to say, well, since you already understand your business operations and what questions you are trying to answer, let me see if I can actually help you design the systems in a way where you can help answer those questions and they become the subject matter expert. Hopefully that addresses that question.
Thank you, Mayor.
Katie, this is Ferris coming back in. Thank you for facilitating the questions and the chats that have been going back and forth. And Mayur and Marina, thank you so much for the insights and information and your experience that you've shared today, and the dimensions of the platforms that are needed to function. I do, Mayur, have your Rubik's Cube now mentally in my mind. I also appreciated and had not gone further past data and analytics, but you and Marina have highlighted a number of the other HCG top 10 issues. Cybersecurity is, of course, there. Just this week, LabCorp and Quest have taken that hit. It is a number one consideration, and I'm glad you highlighted that. But operational efficiency is number 8 on the top 10, and of course, you both drew upon population health and value-based relationships as critical components. These are all critical issues for further discussion, and we invite everyone on the webinar today and others to join us in Boston the early September 9th through 11th for our annual forum. Our overall mission is guiding healthcare executives through innovation, change, and growth. The specific theme for this year's annual forum is digitize, which Mayur and Marina have talked about today, to connect, to put the pieces together, and to transform healthcare. You'll see, and it was just by chance, we're at the Hotel Commonwealth right across the Mass Turnpike from Fenway Park, and we had our sponsors step up and offer to have a peer-to-peer networking opportunity at the left field deck, food and beverage, the night of a Red Sox-Yankees game, September 9th. Seating is limited, so please get your registration in as soon as possible. You can register by going to our website or directly to hcg.org/Boston, or to email myself or Juliana Ruiz in terms of any questions or things we can do to help you. We want to thank all of you for attending the webinar, your interest and your participation, and especially to thank eCube Health for putting this together, and all of the efforts to help address this top 10 issue of data and analytics. With that, we will wrap up the webinar and wish all of you a great rest of the day. Thank you.